all see my screen and you can hear me, yeah? Hello?
Yes, Prof. Loud and clear.
Thank you very much for the invitation. These are such important topics to discuss, and you know, it's difficult to put everything in one session or one day or even one conference, because there's so much to discuss. I'm going to approach this topic from the clinician's perspective, because there's so many angles to this topic, from the histopathologists to the radiologists to you know, all sorts of experts that are involved with maternal and fetal care. So I will try and approach this from a clinician point of view and try and make a few practical points. But starting from the very beginning, when we screen in pregnancy, our aim is to reduce the number of neonatal morbidity and mortality and maternal morbidity and mortality. And I have listed there 4 categories or 4 groups of reasons why we have adverse outcomes. And as you see from the pie chart below, the majority of neonatal morbidity and mortality is actually due to prematurity, and the second biggest group of adverse outcomes is intrapartum related events. So when we talk about prematurity, this can happen for 2 reasons: either because the environment where the baby lives in is not friendly to the baby is not happy in there, and we need to take that baby out to save it, or because the uterus cannot keep the pregnancy in, call it cervical incompetence, or also there are other issues as well, but for the sake of time, call it the main culprit would be the inability of the cervix to keep the baby in, and this baby comes out prematurely. A recent study that was published in the Lancet in 2019 from Chris Hani Baragwanath Hospital looked at the causes of stillbirths among women in our cohort in Chris Hani Baragwanath Hospital. And as you see, a big number of those stillbirths were due to hypertension, nearly 20%. And also pathological placenta conditions, another nearly 20%, which I believe overlaps with the first group of hypertension. So if you combine the 2, you get nearly 40% of the cases of causes of stillbirths are due to hypertension and placenta pathology. And there are other issues. There are the maternal medical conditions, infections in the pregnancy, which I must add is very underestimated and underreported in our setups. Infection kind of gets spoken a lot less than what it should be. And interestingly, in that cohort that was studied at Chris Hani Baragwanath Hospital, although there was a fair number of HIV positive patients, none of the stillbirths that were reported in this study were recorded as being caused by these infections. A recent report by the World Health Organization that was published in 2020 highlighted a problem that we always know, we are aware of it, and we struggle to accept that this is entirely true. But nevertheless, in 2020, the World Health Organization reported that about 70% of all maternal deaths were in sub-Saharan Africa. That's us, which is more than double that is compared to the global rate of maternal deaths. And the leading causes, according to the report, were again severe bleeding, high blood pressure, pregnancy-related infections, and complications from unsafe abortion and underlying medical conditions aggravated by HIV, malaria, and so on. The challenge, of course, with placenta ischemia and and preeclampsia that eventually lead to fetal growth restriction is multifactorial. If it was one condition that causes placental insufficiency and preeclampsia, that would be easy to manage. But because it's so multifactorial, it is challenging to diagnose and to treat appropriately. So it could be due to fetal problems, such as chromosomal abnormalities or genetic syndromes, could be due to maternal issues, idiopathic chronic disease, abnormal placentation, and conditions such as preeclampsia, HELP syndrome, antiphospholipid syndrome, and so on. It could be placenta problems, mosaicism, or abnormal uterine anatomy. And you've heard with the previous speakers the term of velamentous insertion, which can often lead to IUGR. And of course, external factors, environmental factors, smoking, alcohol, drug usage, and so on. We know from years of looking at these conditions that there are some common culprits that we know are strongly associated with ischemic placenta disease, such as hypertension, abnormal uterine artery flows, and the issue of thrombophilia, not just antiphospholipid syndrome, but thrombophilia in general. And I'll come back to that in a few minutes. And other less probably significant factors such as family history, previous preeclampsia with a previous pregnancy, advanced maternal age, and of course, youth is a good thing on the side of the mother. And funny enough, a bit of smoking seems to be beneficial in terms of preeclampsia, although obviously smoking, as you know, has so many other adverse effects. So we wouldn't really promote smoking to prevent placenta ischemic disease. Looking at our own clinics at Chris Hani Baragwanath Hospital, from our antenatal clinics, we can see again, and I highlighted these in red and blue, 11% of the patients that present to our antenatal clinic are due to hypertension. Diabetes is very high, 7%, poor obstetric history, about 4%, and the issue of twins mustn't be underestimated, because I will show you a slide later, also contributes to the placental disease and preeclampsia IUGR. We have now learned a great deal about preeclampsia, and we're dividing preeclampsia now into early preeclampsia and late preeclampsia. The early preeclampsia is the one we all understand and learn from medical school, that will present with the asymmetrical IUGR. The Dopplers will gradually become abnormal. This baby struggles to grow beyond 500 or 700 grams. And those are easy to diagnose because the blood pressure will go through the roof. The baby is not growing, but difficult to manage and have a successful outcome. The late onset preeclampsia, which is mainly, I would say, placenta aging, is more difficult to diagnose and often remains undiagnosed, because how often do we hear from history from our patients that they had a previous pregnancy and the baby was 2.4 kilograms, and you say, but was it full term? Yes, it was full term. Did you smoke? No, I didn't smoke. And I believe these cases actually were missed, and these cases could well be late onset preeclampsia and fetal growth restriction. Thankfully, the majority of these cases end up being okay, have a good outcome, and even if we don't miss them, it's not a train smash, although this can be debated, that is not completely unproblematic. Of course, the challenge is, if we don't see the patients early enough to classify them into high risk and low risk, and we see them when the preeclampsia or the pregnancy-induced hypertension and IUGR set in, they enter one common pathway, and sometimes it's very difficult to go back to the beginning and be with certainty, make a statement regarding the underlying pathology. Once the poor placentation sets in, and that's obviously in the first trimester, Regardless of the cause, the placenta eventually will become insufficient to provide adequate nutrients and oxygen to the baby, and the baby will not thrive, will not grow, will become growth restricted, and the mother will develop the symptoms of preeclampsia, which is in a way, as a simple explanation, an attempt, if you wish, to reject that fetus because it's immunologically is not really friendly to the maternal body, and this can lead to all sorts of problems. The mother goes into severe organ failure, blood pressure goes through the roof, and of course, the placenta can also separate prematurely and cause placenta abruption. So what is the key word here is early assessment is key to manage a patient properly and based on what you have identified as the underlying cause. We have learned a great deal about screening for preeclampsia from the first trimester, and I have put in just two groups of biomarkers. The one is the biochemical markers, which is the PAP-A, the placenta growth factor, and the S-fleet over PLGF ratio, and I will speak about these things in a moment. And the biophysical markers, which is basically essentially the blood pressure and looking at the uterine arteries. And by doing so, early in the pregnancy, we are able to classify low risk and high risk, and those who are high risk, obviously, with appropriate medication, we may succeed in having a good outcome. Even if it's not a full-term 3.5 kilogram baby, will have a good outcome. So if we dissect those two statements, the biomarkers, the biophysical and the biochemical markers. Biophysical markers, looking at the uterine arteries is one of the easiest things nowadays we can do with our ultrasound. We look at the uterine arteries, and if we see good endostolic flow, that's a good thing. It means the vasculature, the blood vessels that provide the oxygen and the nutrients to the placenta bed have opened up, became a low pressure system, and that's what you want. But if you see a high resistance system with a notching and a very low endostolic or very poor endostolic flow, that is a sign that the vasculature did not respond well or adequately to the pregnancy hormones, and this remains a high pressure system. And a high pressure system, like a hose pipe trying to water a big garden, if the garden grows bigger and the trees grow bigger and you need to give more water, if your hose pipe is tiny, it will be inadequate to maintain the growth of these plants in your garden. The same applies to the placenta. The biochemical markers, particularly the placenta growth factor and the PAP-A, are very significant nowadays in our assessment of placenta well-being or placenta health. We know that the PAP-A and the PLGF, the placenta growth factor, are much higher in the Black sub-Saharan African population than the Black patients elsewhere in the world. And we say that because of the FMFZim Foundation studies where the PAP-A and the PLGF were analyzed, the Black patients in their cohorts were not necessarily Black sub-Saharan African. We submitted results recently to the FMFZim Foundation of about more than 10,000 patients in our setup, where they have confirmed that the PAP-A and the PLGF are definitely up to the range of about 50% higher compared to the white South African patients and the patients that were studied in the UK. That has great implications because we are probably providing a poor service to our Black patients because we didn't realize that a higher that they come with a higher with a PAP-A that may look normal based on our results from the FMFZim Foundation, but that actually would mean this patient has a low PAP-A because by default, that patient should have a higher PAB-A, if you understand what I'm saying. So the PLGF is one of the things that we have looked at, and we know that the more PLGF we have and the less soluble fluid we have, the better it is. And that obviously raises the next point, which is, okay, if we know that low S fluid and high PLGF is good, why don't we look at the ratio of those two and try and make a prediction? That's exactly what happened. Studies were published, and one study was published in the New England Journal of Medicine already some time ago, the so-called prognosis study, where they showed that when you have a low ratio of S fluid over PLGF, that's a good thing, and that's mainly for the second and third trimesters, as a good negative predictive value test to say that a patient with a low ratio is not about to develop preeclampsia. And a patient who has intermediate or high ratio, then obviously that patient is probably destined to develop preeclampsia in the next couple of days or weeks. So the beauty of obviously these comments is that a patient who has a low ratio, even if she presented to, say, Baragwanath Hospital labor ward with high blood pressure, that's a high blood pressure probably caused by something else, and probably that's a transient phenomenon and not a patient that is destined to develop preeclampsia. Again, remember what we said about the ratios. With these studies were done in North America and Western Europe, and did not necessarily include Black Sub-Saharan Africans. Now, with the new values in mind, that the PAB-A and the PLGF in our cohort here are higher, then these numbers need to be revisited. And that's the second study that we are currently performing to see what are the correct values for our patients in our cohorts. The PAB-A, we always did a PAB-A as a marker for Down syndrome. We always suspected the issue of PAB-A and placenta function, but again, we didn't have enough strong data to use the PAB-A as a predictor of good or bad outcome. But now we have enough data to know, and we have looked at our own numbers in our university, and we know that the lower the PAB-A, the higher the risk of a patient to develop high blood pressure, abruptio, and for the baby to end up in a neonatal ICU. So I remember many years ago when I was talking at a meeting about routinely looking at the uterine artery Dopplers and measuring the blood pressure, a lot of people, particularly private gynecologists, had a problem with it, and they said, but that's not for you to tell us whether the patient has a high blood pressure or not. That's our job. For you, your job is to look at the fetus and tell us if the baby is abnormal. That was such a wrong statement. We had an argument then. We still argue with some people today, but it is here, and this is a slide from Kypros Nikolaidis from the UK. If we look from the first trimester at the uterine artery pressures, the mean arterial pressure of the mother, and put either the PLGF or the PAB-A or both together in the first trimester, we have such a fantastic detection rate that nobody should be arguing about this. Kypros Nikolaidis, for a very long time, looked at the value of aspirin in terms of prevention of preeclampsia. Many years ago, Chris Yu, who was one of the fellows in London in 2003, looked at the value of aspirin in the second trimester, combined basically with a 20-week scan. And those who had abnormal uterine artery Dopplers and so on were given aspirin, but the results were completely similar to those who received placebo. The answer was it was too late. Then fast forward many years later, aspirin was same amount of aspirin, but was given in the first trimester to patients who screened positive for preeclampsia, and that worked pretty well. I know I'm taking a lot of time, so I'm going to go a bit faster. Why doesn't aspirin work for everybody then? It would be your next question. If we give it early enough to the patients who screen positive for high blood pressure and preeclampsia, Why doesn't it always work? Because there could be unaddressed other pathologies with the patient that we haven't identified. And that brings me to the next slide, that we need to actually get a good history and try and identify personal risk factors that will contribute to an abnormal placentation and high blood pressure and preeclampsia and abruptio and IUGR and so on. And these are listed here. There could be just history of cardiac disease or blood pressure or renal disease, could be metabolic issues, obesity. Ask the patient to lose weight. Don't be embarrassed. Patients need to, they have a responsibility as well to be in good shape when they embark on a pregnancy. And the issue of thrombophilia, of course, both inherited and acquired, and that's where the antiphospholipid syndrome comes in, where anticoagulation should be considered. I'm not going to spend any time on the antiphospholipid syndrome diagnosis because I disagree as a principle with this kind of slide where we need to test patients, and if the results are positive for antiphospholipid syndrome, we need to repeat the tests 3 months later, and if that is confirmed, then we classify the patient as antiphospholipid syndrome. That's nonsense, of course, because you cannot afford to wait for 3 months in pregnancy. The baby will either be dead or both mother and baby may be in serious trouble. So we have to make peace with that, that if we have the clinical history, in other words, the 3 consecutive first trimester losses in a normal morphologically fetus, this patient, for example, would be classified as thrombophilia and will probably require anticoagulation. So aspirin and Texan, heparin, low molecular weight heparin seem to work pretty well. Again, it may not be the complete package. We may need to look at other things that can work as an adjunct to the anticoagulation to optimize results. Again, a lot of these things are still coming in as experimental, and we are looking at these values still as we go. So I said earlier that something about multiple pregnancies. We know that with multiple pregnancies, twins and triplets, the risk of having high blood pressure, preeclampsia increases. And again, the comparison between monochorionic and dichorionic twins, also you see the monochorionic twins double the risk than dichorionic twins. Diabetes, again, something that in South Africa is very, very underestimated. We don't ask the right questions. We don't screen our patients routinely, but diabetes is a vascular disease. So, and if you have a condition that affects vessels, the endothelium, like with our earlier slides that I showed you, these patients need to be put routinely on low-dose aspirin if they are diagnosed with diabetes, either chronic or gestational. So we need to understand how the fetus reacts to the undernourishment from the placenta. Initially, the fetus will reduce its growth, but will still be kind of within the normal ranges. Eventually, at some point, the growth will cross the line of the 10th percentile, and we will call it intrauterine growth restriction. At the same time, the body of the fetus tries to protect the vital organs, such as the brain and the heart, and neglect the kidneys, and therefore underperfusion of the kidneys will lead to oligohydramnios, and eventually the baby starts being compromised, and that's where the CTGs become abnormal, and this baby then needs to come out, otherwise the baby may end up being damaged. So when we talk about absent end-diastolic flow or reverse end-diastolic flow, we need to understand that these things they're very strong statements. Absent end-diastolic flow or reverse, particularly end-diastolic flow, means more than 70% of placenta is not working. And if you have only 30% of the placenta working, as the baby grows bigger and needs more provision of nutrients and oxygen, it will not get them, and therefore will be growth restricted. I will leave the next to the MCA and the ductus venosus because I'm sure at this level everybody understands the significance of this. And I will go to the very, very last slide, and I'm going to leave it there, because I want to leave you with a clear message. We need, Kypros Nicolaides many years ago spoke about the inversion of the pyramid of care. And together with that inversion of the pyramid of care, we need to understand what it means. We cannot just say, let's invert the pyramid of care. We need to have a clear plan of action in our practice to try and identify those who are at risk. For example, even before pregnancy, address those personal risk factors, lose weight, for example, put them on anticoagulation if they have coagulation issues, sort out their general health status. And then once she's pregnant, we need to look at, obviously, assess the fetus for abnormalities, but also get a good history, measure the blood pressure, look at the uterine arteries, look at the biochemical markers if we have them, if they're available, and start with aspirin or aspirin plus other things, depending on what is the underlying condition. And when we get to the third trimester, is there a place for a routine third trimester scan? No. But those who screen positive and you worry about them, you will monitor them in the third trimester. And those who have early growth restriction, and if you have reverse or absent diastolic flow, you may want to deliver them at 34 weeks or 30 weeks, or if the ductus venosus is abnormal, even earlier, provided your facilities can obviously support these seriously growth restricted babies. And of course, the issue of the late IUGR, which is, as I said, a lot less serious, if you wish, but also a lot more complicated to diagnose. But if you do make the diagnosis of late onset IUGR, you may want to consider delivery at 37 weeks, usually by cesarean section. I'm going to leave it here. Thank you, and I will be happy to answer questions later. Thank you.